Hello, everybody. Good morning, and I hope you are all well. Thank you so very much indeed for joining this bowel cancer awareness session. My name is Dr. Saeed Rafi. I'm a consultant medical oncologist at Mediclinic City Hospital in Dubai. We are very thankful that you have made this effort to join this session. And what we're going to do in this session, we're going to have a review of what is bowel cancer, and what is the incidence of bowel cancer, the risk factors for the bowel cancer, different stages, and the screening of bowel cancer. So if you bear with me, this is going to be around 20 minutes or so for the presentation. Then we're going to have ample time for the questions and answers as well. Right. So to begin with, what is the bowel? So if you look at this picture, this is kind of an animation of the alimentary tract or gastrointestinal tract, starting from the mouth. The long tube is the esophagus, which is the food pipe, and this is going to bring the food to the stomach, and then subsequently the food is processed and digested in the small bowel, and then the remainder of the food, which is undigested, it goes to the large bowel. There will be some sort of absorptions and processing here in the large bowel as well, and eventually the waste goes out of the body. So the large bowel has a kind of a starting point. We call it a cecum here. Then it is going up. We call it ascending colon, and then it is going sideways. We call it a horizontal colon, and then it is coming down. This is descending colon. This part is the sigmoid colon, and this part is the rectum. So the whole of this large part, it is called colon. The small ones in the middle, they are obviously a small bowel, and the part right to the end is called rectum. So that is as far as the definition of what the bowel is. So the light orange one is what we call it a bowel. So if you look at 2020, unfortunately, cancer of the bowel, or we call it colorectal cancer, was the third most commonest cancer in the world. Around 1.9 million people, they got diagnosed with colorectal cancer. So if you look, that puts colorectal cancer third one in the rank after breast cancer and lung cancer. The incidence of colorectal cancer is similar in both genders, in men and women. It is standing as the third most common cancer in the world. Unfortunately, out of 1.9 million people on annual basis who get colorectal cancer, around 900 of these people, sadly, they die as a result of colorectal cancer. And when you look at the cancer-related death, it is actually a very lethal cancer, although that this is the third most common cancer. It is the second cause of cancer-related death in the world, just after lung cancer. If you looked at the previous photo, breast cancer was the first one, which around 2.2 million cancers in the world. But breast cancer is not actually the most lethal one. It is only, 684,000 people, they die as a result of breast cancer. But although that, colorectal cancer was the third most common, but it is the second most cause of the cancer-related death. So as such, it is really important to know colorectal cancer, how to diagnose it, how to diagnose it early, and how to treat it to give these people the longest life as possible. So this diagram, it shows you the top 10 and top and the bottom 10 countries with estimated of the incidence of colorectal cancer in 2020. You see that some European countries, Hungary, Slovakia, Norway, the Netherlands, Denmark, Slovenia, Portugal, they have a high incidence of colorectal cancer. The same with Japan as well. In some African countries and some Asian countries, it is less common. So you can see there is a stark difference between these countries. So that we will come to discuss that in a second. But that is a kind of a variety of the incidence of colorectal cancer around the world. Unfortunately, the situation is not going to improve. If you look at this map, this is a projection of what we have in 2020 and what we're going to probably be having in 2040. So you see that in almost all the countries around the world, we will have increase in the incidence of colorectal cancer. In particular, when two countries, they probably they come into mind. One is China, currently around 500,000 patients in 2020 are diagnosed in China with colorectal cancer. It is expected to be short of 1 million people annually in 2040. The same with the US. You can see that currently around 155,000, and it is expected to raise to 200,000. And you have different countries, either the same or higher incidence of colorectal cancer. So certainly the incidence is on the rise, and we have to be very mindful of that. And sadly, this will also lead to more estimated number of deaths in 2040 as well. So out of around 900,000 patients that are going to be in China in 2040, around 500,000 of these people, they are expected to die, sadly. So we have to be aware of the risk factors. What is it, the risk of colorectal cancer, and how can I modify my risk factors? So there are two different type of risk factors, but let's just go for the non-modifiable risk. There is nothing that I can do about these risk factors. Some people, they have a family history of colorectal cancer. They have come up with a faulty gene that they have inherited from their family. They cannot do anything about that one. You cannot modify that risk, but you have to be aware of that risk. And that by having that certain gene, you are more likely to get colorectal cancer. So it is very, very important for you, if you are carrying one of these genes, to just go and have a regular checkup. Yesterday, actually, I had a lady who's been born with a abnormal gene. We call it APC gene, and unfortunately twice she has got colon cancer. So this is very important to be aware of the genetic risk factors for colorectal cancer. If you've had a colon cancer before yourself, you are more likely to get that one. And again, this is not a risk that you can modify. Some rare diseases, we call it bowel inflammatory disease. They put people at a higher risk of developing colon cancer, such as ulcerative colitis or Crohn's disease. These two diseases, they are inflammatory bowel diseases, and they put the risk of colorectal cancer at a higher than normal. Aging is also a non-modifiable risk. We cannot help it. We will get older, and as you get older, we know that there will be more cell replication leading to colon cancer. So this is something that unfortunately cannot help with. But it is important to know that as we get older, we have to be more aware of it, and we have to do more screening. And again, some other genetic risk factors that we just discussed previously. But there are something that we can do actually to modify our risks. Again, obesity is the most common known risk of colon cancer, and it is really common in many countries. So obesity is on the rise, and we have to be very mindful that our lifestyle is getting really sedentary, and then we have to do something about it to reduce the risk of colon cancer. These days, we've had a higher intake of fat and red meat and processed food, and we are not taking as much as vegetables and things as in the past. And therefore, by changing our diet and lifestyle, we know that really it is going to put us at a higher risk of colorectal cancer. Again, this is something that we can modify. It is in our hand. We can change our diet to reduce the chance of colon cancer. Smoking, again, is another known risk of colon cancer, the same as alcohol consumption. And these two, again, these are the things that it is in our hand, and we can definitely modify the risk by stopping smoking and reducing alcohol intake. Looking at the incident, how much of those actually risk factors, the kind of hereditary risk factors, they are playing a part. Majority of this, you see that the yellow bit of this is actually around 60% or so of the colorectal cancer, 65 to 80% of colorectal cancer. And these are the sections that are modifiable. We can do something about it. Yes, I said that, if you are born with the abnormal genes and, family history and so on and so forth, you cannot do anything about it. But these are, forming a small sections of relatively small sections of colorectal cancer. The most common ones are the sporadic ones, and probably these are the ones that are linked to diet, exercise, and obesity. Now, if you look at the natural history of developing colorectal cancer, we do not actually immediately normal cells become cancerous. This part is your normal mucosa. Your bowel is, it has a inner layer, so it is a lining inside. That is the pink one in the middle. Then you have a submucosa, which is the white one. You have the muscle, which is the pink one again, and you have something we call it serosa, which is the outer lining of the colon. So the cancer is almost always coming from the inner lining of the colon. So your normal lining becomes a polyp, and that polyp then start to become cancerous, stage 1, and then go through the wall and progresses to become a stage 4 disease. So ideally, what you want to do is obviously to try to catch things at this stage. So again, this is your normal colon, and this is the cancerous time, and then things will not become cancerous immediately. It is over a period of time, which is expected to be around 10 to 15 years, that we have the progression from the normal mucosa in the colon to become an adenoma, which is a precancerous one, to the cancer one. So this really tells you that the consistent exposure of your body to a certain lifestyle, smoking, lack of exercise, obesity, and so on and so forth, are the ones that basically they contribute to the cancerous progression from a normal colon. Again, going through this one, ideally what you want to do is that you want to avoid this red circle here. You want to avoid diagnosing people at a stage 2, 3, and 4. You really want to diagnose it when it is very small, like a polyp, or at least a very, very small stage 1 disease, rather than something that has become a stage 4. And a stage 4 disease is the one when it has gone to the lung, liver, or other part of the body, and there is nothing that you can do about this, and you cannot cure this patient. Whereas if you actually diagnose patient at the earliest stage, stage 1 or 2, it is possible to cure these patients. So what can I do to prevent? And, obviously, like I say, modifiable risk factors, you can modify, quit smoking, follow a healthy diet, and then have more regular exercises. And if you are following that, you still really need to be aware that even with modifying all your risk factors by the virtue of getting older, we have a higher risk of having a colon cancer. So it is really important to go for a regular screening. I'll come to the screening in a second, but this is the current screening that in the UAE, at least in some part of the UAE, the recommendation of Department of Health is to screen men and women above the age of 40, either with a stool test or with a colonoscopy every 10 years. And the benefit of the screening, as we said, that first of all, it reduces the incidence of cancer because, we are removing the abnormal polyps, and by removing the abnormal polyps, obviously, you're going to stop the development of cancer in that polyps. And once we diagnose it as early as possible, obviously, we're going to reduce the number of deaths and the mortalities from that. Of course, there are quite a lot of economic benefits as well as personal benefit. Having colon cancer, it puts a huge burden in the country's health system to treat this patient. And of course, improving quality of life. Imagine, God forbid, somebody is diagnosed with an incurable stage 4 disease, as opposed to somebody who can have a polypectomy with a colonoscopy and remove the polyp. So there is definitely no comparison of the quality of the life of person who's just had a small polypectomy compared with somebody who's had a stage 4 disease. For this reason, there are different types of colon cancer screening. One is the home base. You can do it at home. The fecal occult blood, basically, it is just looking at small fragments of the red blood cells in the blood. We can do some immunochemical testing. We call it the FIT testing. You can look at the DNA in the blood. These are non-invasive. Basically, you just collect a small portion of the stool, and then you can test these. But we also have a hospital-based screening, as you can see from the top, which can be colonoscopy. These are the techniques and the way that we do it these days. They have improved quite a lot, and doing a colonoscopy is a very routine. It is fairly convenient, and it gives us a direct access to the bowel, so that you can see if there is any polyps or anything. You can remove polyps at the same time to prevent these polyps becoming cancerous. So colonoscopy has now become a standard of colon cancer screening, and recommended for a lot of people, especially if you are above the age of 50. It is recommended. It is fairly, although that it is still categorized as an invasive thing, but it is fairly non-invasive, to be honest. These days, most of the hospitals, they have expert gastroenterologists that they can do it. We have gastroenterologists here. I recently did one colonoscopy for myself, and to be honest, it is fairly convenient way of doing it. We have other things as well, such as flexible sigmoidoscopy, which only goes to the first part of the colon. You have contrast barium enema or CT scan. These two, they involve radiations, and possibly we do not do it on a routine basis. We just do a colonoscopy more commonly. But if there, for any reason, we cannot do colonoscopy, again, these are the tests that we can do it. More recently, we have blood-based tests to just look at the fragments of cancerous DNA, which could be in the blood. These are not FDA approved yet, but I suspect that within the next decade or so, this is also going to be routine in checking as well. So the non-invasive one, which is the fecal immunochemical test, we have shown in various studies that by doing the fecal occult blood and fecal immunochemical test, we can reduce the mortality of this patient. We can reduce the number of the colorectal cancer mortality between 9 and 22% in different countries. This has been proven. So imagine that, if you're reducing 1 in 5 deaths from colon cancer, which is basically 20%, is really very valuable. The immunochemical test, they are more sensitive than the blood test. The sensitivity around 73 to 88%. It is the specificity at around 90%. You do not need to have any bowel preparations or anything, just collecting this tool. The compliance is, sometimes is an issue. Some people, they don't want to do it, but again, around 50 to 67% of patients in different studies in different parts of the world, they were compliant with that. So in terms of who should have this screening, the current recommendation is men and women age 50 or above must have a colonoscopy, at least one in 10 years. You have to have a colonoscopy. People who have a higher risk of disease, either because, like they have Eastern European ancestry or African American ones, those people with a personal history of colorectal cancer, those people who've had polyps and inflammatory bowel disease, they must have a colonoscopy. Patient with family history, and those who have a higher risk kind of lifestyle, such as those who drink a lot and smoke, and they have a high consumption of fat and low fiber diet. These are people who also should have a regular colorectal cancer screening. In short, around 9 in 10 bowel cancer patients who have colorectal cancer patient, and we found it early and they were treated, they survive. So you see that survival rate for patients who were diagnosed at earliest stage, whether it was a cancer in the polyp or stage 1, 90% survival rate. So it is extremely important really to follow the guideline and to do the screening. So again, a simple message: if you are above the age of 50, please go and see your doctors for colon screening. So that was a kind of a little bit of overview. Thank you so much indeed for listening. I realized that I've been speaking for around 20 minutes or so, so I just pause here in case that anybody has any question. Thank you. Just to let you know that you can post your questions in the chat box, or you can unmute yourself and ask any question.
So, Doctor, there are a couple of questions I'll read out for you to answer. So, going to the first question: how adenoma stage will be cured? Like, what is the treatment plan for adenoma stage?
I am sorry, we have a little bit of background noise and I couldn't really hear you very well. Would you be able to repeat your question?
Yes, definitely, doctor. So my question is, how is adenoma stage cured? What is the treatment plan for any cancer which reaches to adenoma?
Right, so adenoma is not cancer, so these are usually polyps, which are basically growth in the lining of the bowel. They have not reached the change in the cell composition to become cancerous. However, they have the potential to become cancerous, so they are kind of classed as a precancerous lesion. So So usually when you have adenomas, where you have certain look and the risk, and the people, they usually remove them during colonoscopy. So when we do the colonoscopy, our gastroenterologists, when they see a polyp, they don't really know what it is, but usually if they feel that they are pedunculated or they look abnormal and they are reaching a certain size, they usually remove it during colonoscopy. One problem is finding polyps in the bowel when they are doing it. Yes, when they are doing colonoscopy,
Doctor, I
one
think you're
problem.
stuck. I'm not able to hear you.
Hello?
Just bear with us. We have lost doctor's connectivity.
Can you hear me? Okay, so let me continue. So what I was saying is that, sometimes finding polyps in the bowel.
I think we lost you somewhere. So can you repeat?
So Veena, I don't know if you are speaking with somebody else, or can you please tell me what is the question?
So, doctor, we lost the connectivity. We could not hear you in between. You were on the last section of the answer for the adenoma stage, where you said that adenoma is not cancer, and after that we lost you.
Okay, all right. Okay, thank you. So basically, yes, adenoma is just like a growth of the cells in the lining of the bowel, which they have. It has not actually achieved the changes bad enough to become cancerous. So it is not a cancer. It is some adenomas, they are precancerous, but our gastroenterologists, basically, they tend to remove all the polyps that they see in the bowel, and then subsequently our pathologists, they have a look at it to see whether there was any changes in there. Sometimes you have a small amount of cancer within a polyp or within the adenomas, but if they have been within the polyp and not gone into anywhere else, these are really a very early stage cancer, and polypectomy seems to be a curative option for these patients. One thing is that when you do a colonoscopy, the colon is not a straight pipe. It has a lot of folds and things, and sometimes these polyps, they are hidden in the folds, and you cannot see those polyps very well. And these days we have a lot of technology. One technology is combination of artificial intelligence with colonoscopy, and artificial intelligence directed colonoscopies, they are now becoming very popular because they are able to identify the polyps that they look more suspicious, or they are within the field and something. So it helps our gastroenterologists to be able to recognize the ones that are higher risk, or the ones that are hidden, and subsequently to remove them. Recently in Mediclinic, we have also brought this technology, and it is available. So it is actually a very, very helpful technology for us.
Doc, next question is related to IBS. Is it related to colorectal cancer?
Sorry, I think, because there is a little bit of background noise, I cannot hear your questions very well.
Doc, is IBS related to colorectal cancer? IBS.
What is, IBS? IBS, if you are calling irritable bowel syndrome, no, it is not related to colorectal cancer, but inflammatory bowel disease, as we discussed, such as Crohn's disease or ulcerative colitis, yes, they are, but irritable bowel syndrome is no, is not related.
Is colonoscopy procedure painful?
And not really, because they put you either on deep sedation, so you do not feel, or sometimes they give you anesthesia. When you go and have your colonoscopy for 2 days, you have to have some medicines to clean your bowel. And then after that, you go to hospital and they put a cannula in your arm, and through the cannula, they give you some medicine, and it makes you very sedated, so you do not actually remember anything. So it's not a full anesthesia, it is a deep sedation.
Understood. Doc, what are the main symptoms at a very preliminary stage, at the starting stage? What are the signs and symptoms someone should look for?
Sadly, you will not have any signs and symptoms during the early stage. This is why if you want to only rely on the symptoms, you will never find any symptoms until it becomes late. And then, for instance, if you're waiting for a weight loss, or, bleeding from the back passage and this kind of stuff, it is already too late. So this is why just relying on signs and symptoms, it is not really very accurate. It is probably best to go for the screening before you even develop any symptoms.
Is there any chance, what is the genetic factor for this type of cancer for bowel?
There are two, there are multiple different genetic things, but there are two that are, stands out. One is a condition called FAP, or familial adenomatous polyposis, and that is where, all the members of the family, they have a colon which is full of polyps and adenomas that they can become cancerous. And the other one is a condition called HNPCC, which is hereditary non-polyposis colon cancer. So it is a hereditary condition, but your polyps, your colon does not have a lot of polyps in there, like AFP. So these are the two most common ones, but there are other kind of genetic risk factors, although they are not very common, that can increase the risk. If you have one of these conditions, you probably would know, there is somebody in the family who've had a lot of polyps or bowel cancers and things in the past. And if so, if you have a family history of these colon cancers, please make sure that you go and see somebody for the test.
Doc, is there any chance to develop polyps again once removed? Doc, is there any chance to get recurrence of polyps once removed?
Yes, it is. There is a chance. Polyps, they can develop and develop again. So it is important to repeat those colonoscopies. One colonoscopy is not enough. So you have a polyp, you go and remove it, and then later on you may develop another polyp. So this is why it is recommended in some patients who are high risk. They will do it more frequently. For low risk patients, less frequently, but around 5 to 10 years you must repeat.
Doc, how can we recognize any signs of rectal cancer?
Rectal cancer, sometimes, you feel a little bit fullness in the back passage. Some people may have constipation, difficulty in emptying their bowel. They have blood coming in the stool. They have, rectal bleeding. These are the most common ones. So again, you have to be very aware of those symptoms. Essentially, again, sometimes you do not have symptoms and you still have cancer, this is why it is important really to go and have the screening. I would say maybe around 20% at least of our patients are the ones that they do not have any symptom. They have just gone for a screening and they have been diagnosed with colorectal cancer.
There are a couple of questions like, is colonoscopy available at clinics or only at hospitals?
Sorry, colonoscopy available what?
Colonoscopy is available only at clinics or hospitals only. I would want to tell the audience that is something you may want to discuss with the provider you want to visit, but usually it is done in a minor OT or OT setup. Right, doctor?
Correct. Yes. I mean, it usually should be done in a healthcare facility that they at least they have a day case unit. You know, it doesn't have to be hospital, but it has to be a very well established clinic. You know, it is not something that you can do in. You know, it has to have a day case because you know it is a sedation and things involved in that as well. So so you got to do it in a setting that you have a day case facility available.
Doc, is there any specific kind of a diet like, you know, probiotic drinks, yogurt, laban, or diet which is high in fiber can be a measure to prevent such cancer?
Yes, of course, you know, we discussed about high fiber diets and, you know, especially you have to cut down on your red meat, dairies, and then use high fiber diet. You know, if you are a person that you have your bowel transit is slow, meaning that, you know, every 2 days you evacuate your bowel, you have to make sure that, you know, you use more high fiber diet rather than just relying on a meat and you know carbohydrates. So that will help a lot really in making the bowel transit more often, and then when you increase your transit, the less likelihood of toxin building up in the colon.
Doc, taking the last question, if the rectal cancer is treated at an early stage, how can we ensure that it doesn't spread?
That is with follow-up. You know, all patients who have been diagnosed with colon cancer or rectal cancer and they've had surgery and other treatments, we keep them on the follow-up on a regular basis. We see them very regularly in the clinic every few months to do the examinations. Every now and then we do a colonoscopy or CT scans and the rest of it to make sure that we keep a good eye on the cancer and make sure that these patients they do not have a recurrence. Generally speaking, if you've had the treatment, you are free of recurrence of the disease for quite a few years, such as 5 to 10 years, the likelihood of this recurring is very low.
Okay, so Doc, as a preventive measure, what is that you would recommend for an early screening? What kind of test should someone go through?
So of course, you know, if you have symptoms, you have to go and see a doctor immediately. If you do not have a symptom, you are above the age of 50, you must go and start doing a colonoscopy. This is important. If you have any family history or if you have inflammatory bowel disease, if you are a smoker, if you drink a lot, you know, if your lifestyle is in a way that you think that it is going to put you at a higher risk of developing colon cancer, you must go and see a gastroenterologist.
So, Doc, we have taken all the questions so far. Thank you so much for your time. It was really informative session. The cancers are on rise. I hope this session made everyone aware that, you know, how much it's important to have early screening so that we catch the diagnosis early and the prognosis is better.
Absolutely.
would
Thank
like
you
to
so
add
much
something?
indeed for your time, everybody. I wish health and happiness for you all. And please, yes, go and do the screening, not only for colon cancer, obviously, for everything else, but this month is particularly important to be aware of colon cancer. Thank you so much indeed, Vina, for organizing this.